Today I'm going to talk about my favorite topic, which is thyroid cancer, and there's a very rich tradition of endocrine surgery and endocrine neoplasia here at Stanford, most recently with Drs. Norton and now Dr. Kebebu and colleagues. So I hope you haven't already heard too much about thyroid cancer, but I'm going to try to give you sort of my personal perspective on this disease, and I may show some controversial results and promote some contentious debate, and I think all of that is good for the field of thyroidology. And I will confess this is my best slide. They say to start strong. So this is the best. It just goes downhill from here. So as many of you will know, many of you probably know me from Twitter, not from the field of American surgery. So this appeared on Twitter last week. Who else is psyched for the 8th annual Ignatius lecture? Was that you, Dr. Hahn, saying who's psyched? I don't know, but I thought that was pretty cool. So I answered the question. I'll tell you who's psyched, me. And that really, and I think 42 other people felt the same way about this. But just to let you know how excited I have been looking forward to coming to Stanford. These are my disclosures. They pertain only to medullary thyroid carcinoma, and I'll be talking today exclusively about differentiated thyroid cancer. So we're going to start by talking a little bit about advertising, but really about epidemiology. So this is a picture of Brooke Shields. To the best of my knowledge, Brooke Shields does not have thyroid cancer. But this is an advertisement I saw in a throwaway magazine on an airplane ride I was taking, and it's interesting what it says. It says, it's not just looks that can kill. Have your neck checked for thyroid cancer. So the suggestion here in this ad is that you should potentially screen for thyroid cancer, either through physical examination, or one could extrapolate to ultrasonography. And that's kind of interesting because the U.S. Preventative Services Task Force recently released a statement recommending against thyroid cancer screening in the United States, and I'll show you why they did. But I think that advertisement, while maybe out of step with the U.S. Preventative Services Task Force, is at least not inaccurate. And this, you'd think I made this up, but this is actually from another magazine, another advertising campaign. I'm not sure about the taste of the advertising, but it's interesting what it is saying epidemiologically. And the first thing it's talking about is incidence of thyroid cancer in the United States. And here I would say there is accuracy. Thyroid cancer is growing 7 times faster than breast cancer, so that's clearly targeted to women. Here, targeting men, thyroid cancer is growing 5 times faster than testicular cancer. Both of these are correct epidemiologic observations about incidence. But then look at the conclusion that is drawn. Ask your doctor to check your neck. It could save your life. So they extrapolate from a high incidence rate to what must be an equally high mortality rate. But in fact, thyroid cancer is an indolent disease, and while it is increasing in incidence, mortality is fortunately low for differentiated thyroid cancer. So interesting inaccuracies, and certainly not the first inaccuracy in advertising. So what do the hard data show? And these are the hard data, and what we know is that there's virtually an epidemic of thyroid cancer in the United States. The incidence has increased by more than 300% in the last 3 decades, and this is being observed in all demographic groups, women, men, young, old, black, and white. And many would argue it's actually a pandemic in that every developed and developing country in the world is experiencing similar rises in thyroid cancer. When I finished my training in residency, thyroid cancer was the 8th most common cancer in American women. By 2016, it had become number 5, and it is anticipated that by 2019, it will overtake both uterine and colorectal cancers to become the 3rd most incident cancer in U.S. women. So what is going on, right? Really interesting phenomenon. What is the etiology? So there was a pivotal paper, a seminal paper in JAMA in 2006 by Welch and Davies, and I've plucked from that paper 3 sort of important figures. Let's start in the upper left-hand corner, and here you see incidence of all thyroid cancers largely being driven by an increasing incidence of one unique histologic subtype, which is papillary thyroid carcinoma. When I finished my training, it represented about 80% of new cases. Today, it is estimated that 90% or more of incident cases of thyroid cancer are papillary. So that is the engine of the increasing incidence. Then, if we look to the figure to the right, we see papillary thyroid cancer broken down by different sizes, and what you see is the fastest increase is observed in the smallest tumors, those tumors under 1 centimeter in size, which we refer to as conventionally papillary thyroid microcarcinomas. And finally, this really famous figure, the most famous figure from the paper, which shows rapidly increasing incidence with a level mortality rate. So when the authors put all of those three figures together, what they said is we believe increased diagnostic scrutiny is the most likely explanation for the apparent increase in incidence, meaning these tiny tumors are being identified more and more, no one is dying from the disease, so as a result, it is likely the result of overdiagnosis. So is that really the case? Is that really the case? Well, there are some data supporting this, some of our own data. We looked at a 5-year period between 2006 and 2011 in the United States, and in that 5-year period, the number of thyroid biopsies, fine needle aspirations, more than doubled, such that today in the United States, excluding skin biopsies, 2/3 of all solid organ biopsies are actually done on the thyroid gland. And who is to blame for all of this diagnosis? Of course, myself and everyone in this room. And is it having any downstream effect? You sure betcha. The number of thyroid nodule-related surgeries in that same 5-year period in the United States increased by nearly 1/3, and the genesis of that is largely increasing numbers of total thyroidectomies being done, not thyroid lobectomies, but total thyroidectomy. So we've got a story, right? We've got increasing incidence, level mortality, likely overdiagnosis. Have we reached the truth? And you've all seen this picture of the iceberg where most of the iceberg is underwater, and it makes you wonder whether there is some hidden truth here. And I always counter that by saying, well, are there even any icebergs left anymore? And I don't want to get political today, but just as the icebergs are disappearing, so too may be truth. So when I put all of this together, I wondered about the presentation of the data and whether the presentation of the data was appropriately reflecting the actual findings. And what it struck me is that when you put a very high incidence with a very high mortality on an arithmetic Y scale, is it not possible that changes in mortality, while small but relatively great, could be masked? And I wondered, could we change the way we presented those Welch and Davies data? So very simple question, could we move to a semi-log scale and look at the data again? So I called a friend, Carrie Kitahara, who is an epidemiologist at the National Cancer Institute. And for this review article we did for Nature, all she did for me was pop it on a semi-log scale. And what you still see is increasing incidence of thyroid cancer. But now you start to see increasing mortality as well that previously had potentially been muted by that Y scale in the Welch and Davies paper. And with this simple principle, let's relook at the analysis but change the way the data are presented, you too can get a JAMA paper. So this is our JAMA paper from 2017, just 11 years after Welch and Davies. And what we essentially did was redid a lot of their analysis. We redefined mortality, and then we changed our graphic representation. So like them, the source of our thyroid cancer incidence data was the SEER-9 data sets, a high quality population-based cancer registry. Probably many in your in this room have used SEER. It represents about 10% of the U.S. population and is believed to reflect the U.S. population as a whole. It has very granular data about demographic, clinical, and pathologic characteristics of patients with thyroid cancer. We married these incident data with mortality data that we culled from the National Center for Health Statistics. And the next change we made was we did not look at straight mortality. Rather, we decided to look at incidence-based mortality, which is an important difference because it allows you to look at indolent diseases where there are a paucity of death events, but very high incidence, which is the case for differentiated thyroid cancer. We did a lot of our actual statistical analysis like the previous authors. We calculated rates. We looked at annual percentage changes in order to look for inflection points in changing incidence and incidence-based mortality over time. And then importantly, with our figures, we this time moved away from arithmetic scales to a semi-log scale. So let's see what the data now show when you make these changes. So starting with papillary thyroid cancer incidence, what we see is that the incidence of cancer of all stages is increasing. So not just the tiniest tumors, tumors localized to the thyroid, but tumors of all stages, including those with regional and distant metastases. Obviously, these are more advanced cancers that can be associated with mortality. We then broke down incidence by the size of the tumors, and yes, it is certainly the case that those papillary thyroid microcarcinomas are increasing 9.3% per year. But what we see now is that tumors of all sizes, including the largest tumors, over 4 centimeters in size, so these are tumors the size of a golf ball, they too are rapidly increasing in incidence. And is that the likely result of overdiagnosis alone? Almost certainly not. We then went ahead and looked at incidence-based mortality, and what you no longer see a flat mortality rate, but rather you see increasing mortality, such that overall the incidence-based mortality rate is increasing at 1.1% per year. And I will tell you that is pretty exceptional in the United States. We are indeed winning the war against cancer, except for 4 cancer diagnoses. Number 1 is liver, and number 2 is thyroid. We then looked at mortality across different stage diseases, and you see mortality is going up for all of the stages. And finally, you see mortality going up for tumors of all sizes. And in fact, it is going up the fastest for the smallest tumors, those under 2 centimeters in size, at a rate of 6.8% per year. This almost certainly, again, is not overdiagnosis, and what this to me suggests is potentially the underlying biology, the molecular profile of small differentiated thyroid cancers is changing. So what would we summarize by saying? So what we knew before, thyroid cancer incidence has increased more than 3-fold, and in fact at a rapid rate of 3.6% per year. It's being observed for all demographic groups, especially in the arena of papillary thyroid cancer, and for tumors of all stages and sizes. And then a new finding. Incidence-based mortality is not level. In fact, it increased 15% over this long time period at a rate of 1.1% per year, and it is affecting all demographic subgroups, and in fact was greatest for papillary thyroid cancer. So we reached a very different conclusion, I think, than Welch and Davies. I certainly agree with them that overdiagnosis is a large part of the explanation. But the important difference in our conclusion, it is not the only explanation for rising thyroid cancer. And I think we've potentially done ourselves a disservice over the last 10 years by saying there's nothing really going on here with thyroid cancer. Funding and dollars have been diverted from thyroidologists doing research, and I would argue we should be investing in thyroid cancer research and particularly focusing on improvements which are needed in treating patients with the most advanced stage disease. Well, in the end, what it often boils down to is money, right? Resources and money. That's what makes payers, that's what makes policymakers pay attention. So what is the cost of thyroid cancer care in the United States? Well, first of all, it's great, and it's very different from other cancer diagnoses. For most cancer diagnoses that are surgical in nature, the greatest dollars are expended either in the initial treatment, which is typically surgical, or at the end of life, in the weeks or days prior to death. But thyroid cancer is very different. The bulk of the cost of thyroid cancer care is shown in green, and that is in the arena of surveillance. Why? Because most patients diagnosed with this disease are young, middle-aged, they don't die overall, they live with their disease and accumulate the costs of surveillance and remedial treatment potentially over decades. And what are the implications of that for patients and their families? Extreme. So this is a portrait showing financial toxicity, which is a term we use in oncology. And what we know is that any cancer diagnosis affords a patient and their family a 2 times risk of bankruptcy compared to a patient who doesn't have cancer. But thyroid cancer is the cancer that is most associated with bankruptcy at a rate of 3.5 times norm. And this, many people find counterintuitive. They say, how is that possible? How is it possible that thyroid cancer bankrupts people more than mortal diseases like lung cancer, uterine cancer, and pancreas cancer? And it is for the reasons I showed you. Patients have to live with their disease, they accumulate the costs of surveillance, and they accumulate the costs of remediation. Also importantly, because these are young patients who are diagnosed, even in the era of the ACA, it is the young now in the United States who are frequently either uninsured or underinsured. So what should we do about all of this as a medical and surgical community? Well, thyroidologists are no different than other specialists in that we believe that eliminating variation in practice will also potentially eliminate variation in the quality of care. And so we've struggled to put together evidence-based guidelines to drive what we do. The American Thyroid Association is one professional society that has led the way in this arena. They first issued guidelines in 1996. Those were repeated in 2006. 2009, and then they had been anticipated in 2013 because thyroidologists love to argue about very tiny things, how many angels can dance on the head of a pin. We missed the 2013 deadline, we missed the 2014 deadline, and the guidelines came in 3 years late in 2016. I like to think that perhaps this reflects the kinetic of the science that was driving what we are doing. And the guidelines came to something like, 450 odd pages, which no one can possibly read and digest. But if I were to summarize the ATA guidelines for all of you, I would say is everything that is old is new again. And where we are today in thyroidology and the treatment of thyroid cancer is not so different from where we were 20 or 30 years ago. And for those learners in the audience, students, residents, and fellows, these are publicly available guidelines. In fact, probably every week in my clinic, at least one patient will come in waving the guidelines saying, Dr. Sosa, is what you're going to do benchmark well against what has been published. So the ATA is eminently fair and thinks about equity and parity, and so the surgical authors of these guidelines reflected 2 otolaryngologists, 2 general surgeons, 2 were on previous guidelines, 2 of us were newbies. I always point out I think the ATA needs to continue to work on gender equity. So what are the tenets of these guidelines? And I would say many things about the 2015-16 guidelines are not new at all. The goals of initial therapy are shared with pretty much all cancer guidelines. You want to improve cancer-related survival. You want to minimize the risks of recurrence and metastatic spread. You want to facilitate accurate long-term surveillance, and you want to permit accurate staging of the disease. But there was a new maxim in these guidelines, and that was for the first time the American Thyroid Association recognized the importance of minimizing treatment-related morbidity, that is, the over-treatment of thyroid cancer. Now, is that some new, brand new thing that we have never heard of? Of course not, right? Every day as clinicians in our clinic, especially cancer clinics, we have to, on one hand, avoid the undertreatment of clinically significant cancers that could shorten patients' lives. At the same time, we have to avoid overtreating indolent lesions that will not. And how do we do that? We do it consciously or subconsciously by weighing the risks of misdiagnosis against long-term uncertainty, particularly in an indolent disease like papillary thyroid cancer. Increasingly, the patient is at the epicenter of decision-making. Unfortunately, we have to think about medical legal implications and the omnipresent thinking about cost effectiveness. So let's start small and go big. So we'll start with those tiny tumors, papillary thyroid microcarcinomas under 1 centimeter in size, and you've seen this figure before. They're increasing the most rapidly. So what should we do about them? Is less more in this case? So this was a really important thought piece. It was published in 2014 in the journal Thyroid by 2 very famous thyroidologists, and for the first time in the United States, these thyroidologists asked the question, is the identification and eradication of all papillary thyroid microcarcinomas a worthwhile goal, or might it be possible that we safely actively surveil tiny cancers without surgery, which is sort of a revolutionary concept when it was formulated in 2014. I always like to point out the title of this paper, Observing Mycopapillary Thyroid Cancers, and my observation is you better surveil these cancers better than the editors reviewed the text of the article. So what's the challenge, right? The challenge is we have to confirm the appropriateness and the safety of observation. So we have to be able to identify the subset of tumors that are indeed aggressive before they develop progression and in time to be able to rescue or ultimately salvage the patient, correct? So are there any data suggesting that this can be done? And there's actually a very large body of data, not from the United States, from Japan, from a very famous surgeon by the name of Dr. Ito. They've published serially many, many papers about this famous cohort. This is one of my favorite papers from 2014, looking at 1,200 patients with papillary thyroid microcarcinomas, followed for a very long time, a mean of 75 months. These patients were divided up into 3 different age groups, and they were followed for their tiny tumors without surgery. And they were followed specifically for disease progression, as defined by enlargement of the tumor, development of lateral compartment nodal metastasis, or progression of disease to 1.2 centimeters or greater. And these are the findings, and they're really fascinating. And what you find is when you follow patients out without surgery with these tiny papillary thyroid microcarcinomas, you see at a decade that fewer than 10%, just 8%, will experience any enlargement of their tumors, and fewer than 4% will develop nodal metastases at 1 decade. If you then break down these patients into different age groups, what you see is that the proportion of patients with progression was lowest in the oldest patients, shown in the solid line, and it was greatest in the youngest patient, showed in the dotted line. And in fact, on multivariate analysis, young age was an independent predictor of papillary thyroid microcarcinoma. So what these authors importantly concluded was that older patients with these low-risk tumors may be the best candidates for active surveillance if you're going to do it. But even in young patients who have more aggressive and more progressive papillary thyroid microcarcinomas, there is almost certainly enough time to identify the progression of disease and intervene in a way that you can stem a bad outcome for the patient. So this is very promising, and a lot of people embraced this and said, active surveillance, we should start doing this in the United States. And I always say before we say we're going to do something, we should start by looking at what we're doing right now. And this is some research by our group that looked at survival for patients with papillary thyroid microcarcinomas compared to the normative U.S. population. And while those two curves look like they must be different, they're actually statistically significantly the same. But if anything, papillary thyroid microcarcinoma patients live a little bit longer maybe than the general U.S. population. How can that possibly be? Probably because they have more fastidious health care, right, and better access to care. Otherwise, how would the tiny tumor have been identified? But if we then look at what these patients are having done for their papillary thyroid carcinomas, what you see is that nearly 3/4 of patients are having their whole thyroid taken out, which is very different from active surveillance. So right now, most of my colleagues in thyroid surgery and thyroidology stop me and say, that's not true, Julianne, you're misrepresenting the data. Almost certainly these tiny tumors were discovered serendipitously after surgery, and the surgery in fact was performed for some other reason, like Graves' disease, a multinodular goiter, a toxic adenoma. I don't think so, because what we also see is that 1/3 of those patients not only had their whole thyroid taken out for this tiny tumor, but they went on to undergo radioactive iodine ablation, which is clearly overtreatment. Why? Because the recommendations from the ATA is that thyroid lobectomy is sufficient for the overwhelming majority of these patients. So what we're doing in the United States is not at all reflected in the recommendations. But what was new in 2016 regarding papillary thyroid microcarcinomas, and this has often been overlooked, is the addition of the word if surgery is chosen. And what we did with that is we opened the door a crack to permit those of us in the United States who take care of these patients to not operate, but actually to actively surveil tiny tumors. Well, let's go up in size from papillary thyroid microcarcinomas, where less may well be more, and let's talk about the bread and butter of thyroid cancer, which is low-risk differentiated thyroid cancer, which today we define as differentiated thyroid cancers, papillary thyroid cancers, between 1 and 4 centimeters in size, without metastasis to lymph nodes, and without extrathyroidal invasion. So this is the age-old controversy of total thyroidectomy versus lobectomy. So there are two schools of thought, two camps. Those who advocate for total thyroidectomy say, don't we want to eradicate disease that in up to 75% of patients can be multifocal and bilateral? Don't we want to be able to facilitate postoperatively administration of radioactive iodine? And won't eliminating the thyroid and dropping the thyroglobulin level to 0 not make it easier for our colleagues in endocrinology to identify a recurrence? Those who argue for lobectomy counter by saying, don't we want to avoid thyroid hormone supplementation, let alone replacement? In the end, it's an indolent disease with an excellent prognosis, so does it really matter what we do? Aren't there higher risks of complications with bigger surgery? And in the end, show me a survival benefit. So right around now, when I talk to the American Association of Endocrine Surgeons, they raise their hand and they say, Julianne, we're high-volume endocrine surgeons. We can do total thyroidectomy with the same safety, equivalent safety, as we can do lobectomy. So is that the case? Well, first of all, definitely it is the case that surgeon volume is associated with superior outcomes, and this is a figure that is often shown to support that. Lobectomy, total thyroidectomy, low volume going to high volume, left to right, and what you see is for both procedures, the more you do, the less likely it is, on average, for a patient to have a complication. But I like to show this figure for a different reason, and that is to compare lobectomy against total thyroidectomy by volume group. And let's take those high volume surgeons, and what you see is that even in the hands of high volume surgeons, the complication rate for total thyroidectomy is nearly twice that as thyroid lobectomy. So there are greater complications with total thyroidectomy regardless of the volume of the surgeon. So if this is the case, I showed you that figure that showed total thyroidectomies on the rise. Why are we doing total thyroidectomy for low-risk differentiated thyroid cancers? And in fact, why did the American Thyroid Association in 2009 recommend total thyroidectomy for all tumors over 1 centimeter in size? And I would argue it was one study, a pivotal study, an important study, a landmark study, but one study that really supported that recommendation. This is very famous for learners in the audience. This is very famous work, 2007 from Billimori et al. 52,000 patients from the National Cancer Database, and they asked a simple question: is survival equivalent or different for patients who undergo total thyroidectomy versus thyroid lobectomy? And here's the famous table. I'll just cut to the chase. And what the authors showed is that lobectomy is associated with a 31% increase in the risk of death compared to patients who undergo total thyroidectomy. Many eyebrows were raised with these data, but super compelling, significant findings suggesting that total thyroidectomy is associated with improved survival. Now, after that paper was published, some people scratched their heads a little bit, not only because of the size of that observed measurement, but also some questions were raised, not about the scientists, and I want to emphasize that the scientists were fantastic and are fantastic, but about the data set they used. And almost always it comes down to limitations of data, right? In addition, Mendelsohn in 2010 published a similar study, 22,000 patients, and they were unable to identify a difference in survival between total thyroidectomy and lobectomy. These are SEER data, not NCDB data, but still kind of interesting. We don't see this survival advantage. So I'm not always the most creative person. You will learn through this talk, and sometimes what I like to do is go back to old questions and, as you see, either represent and present the data a little differently or change the way we ask the question or the data that are used. And this is a study that was presented at the American Surgical Association, published in the Annals of Surgery. Importantly, the first author is Dr. Adam, who is a third-year categorical general surgery resident at Duke when this paper was published. And what we did in the study was essentially redo the Billimori study, but this time with a national cancer database that was more contemporary and that had been augmented with additional independent variables, demographic, clinical, and pathologic variables, that allowed us to, I think, do more fastidious adjustment around the different kinds of variables that can influence survival. And we asked the same question: is survival associated with the extent of thyroid resection for low-risk differentiated thyroid cancers? So here are the data. These are the data showing demographics of the lobectomy group and the total thyroidectomy group. And I will say, while you will see statistically significant p-values, in fact, the clinical differences are not prominent when it comes to the demographics. But when you look at the pathologic characteristics, these two groups are very different, and these are all variables that were not available to Dr. Billimori and his colleagues at the time of their study. And none of them are surprising. What you see is that with total thyroidectomy, there is more multifocal disease, more extrathyroidal extension, more nodal and distant metastases, more positive surgical margins, and more often radioactive iodine was administered as compared to patients who underwent thyroid lobectomy. But when we put these additional variables and all the old variables into the multivariate regression analysis, what we found is that the survival advantage that had been previously conferred by total thyroidectomy now disappears. And it disappears for tumors 1 to 2 centimeters in size, and it even disappears for tumors 2 to 4 centimeters in size. So in 2009, as I told you, the recommendation had been for total thyroidectomy for these tumors 1 to 4 centimeters in size. And based on the work of a third-year categorical general surgery resident at Duke University, the 2016 guidelines now recommend either total thyroidectomy or thyroid lobectomy for these tumors. Many have misinterpreted this recommendation to say that the American Thyroid Association says thyroid lobectomy is superior to total thyroidectomy. That is not the case. They are both alternatives, and in the end, the decision needs to be made by the patient in conjunction with what hopefully is a transdisciplinary care team. So another case where less may in fact be more. Let's switch gears again, and now we're going to leave the thyroid gland and talk briefly about lymph node metastases, which are seen in approximately 50% of all incident cases of papillary thyroid cancer. And I'm going to start with an overview for the learners, because often this shows up on the ABSITE and on your on the qualifying examination, and that is the staging system for differentiated thyroid cancer from the AJCC-UICC. And they like to ask questions about this. Why? Because it's a super quirky staging system that makes no sense, right? Which is why we like to ask questions about it. And it's very interesting. This is the only cancer where age plays a factor, and this is the 7th edition. We now have an 8th edition, but because the data I'm going to show you are for the 7th edition, we're going to stick to the 7th edition. And what we do is, if you are young, and don't kill the messenger, many in the room will be over 45, including me, but if you're under 45 and young, a lot is forgiven. Specifically, you can only be stage 2 if you have metastatic disease outside of your neck. Your whole neck could be riddled with thyroid cancer, but if you're under 45, you will remain stage 1. So extracervical disease is all that will move you to stage 2. You cannot be stage 3, you cannot be stage 4 if you are under 45, now 55 in the 8th edition. But if you're over 45, we forgive nothing. And cervical lymph node metastases incrementally confer higher stage disease, and as a result are associated with survival. So that's kind of weird, right? You're young and lymph nodes are not associated with survival, and you're old and they are associated with survival. Pretty unique, right? So it occurred to me that that was kind of strange, and I thought, are there any data supporting what the AJCC says? So there are some data. This is our data from Zaid Fudum, who's now a pancreatic surgeon at Virginia, 2008, 15,000 patients from SEER. And when he looked at the SEER data, he in fact saw that for older patients, these lymph nodes are associated with survival, but not if you're under 45 years of age. But then this study came out from 2012 looking at 49,000 patients in SEER, and in this study they were unable to replicate that, and in fact found that lymph node metastases were associated with compromised survival regardless of the age of the patient. So again, this teaching point I'm sort of hammering home. When you see data that are conflicting, sometimes there's an incredible opportunity to ask that age-old question in a rigorous, novel way. And this is a paper, again from Dr. Adam, as a third-year categorical general surgery resident at Duke, published in JCO with an impact factor of 28. And what we did here is we asked the simple question: does the presence of lymph node metastases in young patients confer decrement in survival? And if that were to be the case, is it possible to stratify risk of death based on the burden of nodal disease? So to answer this question, we used two large population-level databases. You've seen them both before, NCDB and SEER. And this is how we designed the study. So we looked at patients with papillary thyroid cancer under 45 years of age who had stage 1 disease, so no one had distant metastases. We had to know how much surgery they had. We eliminated sort of weird variants of papillary thyroid cancer, and we divided the study cohort into two groups: those who did not have lymph node metastases and those who did have lymph node metastasis. And we did some conventional statistical analysis, some univariate, bivariate, and multivariate survival analysis. But what we did was something a little different, and I never could have done this by myself, and this is, the teaching point is phone a friend. So here at Stanford, call Arden Morris, maybe, and her team at Stanford Spire. But I called colleagues in biostatistics at Duke, and they suggested I use something called restrictive cubic splines. And this is where a lot of you who aren't already asleep start to fall asleep, but don't fall asleep, because this is super wicked easy to understand, and it is a great tool to have in your toolkit. So here's the assumption made by multivariate regression analysis, and that is that there must be a linear association between the independent and the dependent variable. And I liken this to your speeding away from the police because you did something bad, and you come to the realization you're never going to outrun the police, right? So you slam on the brakes. And what we know is that the faster you are going before you slam on the brakes, the longer it takes to stop, right? So that's a linear association between speed and stopping distance. Well, Dr. Hahn told you I'm from Canada, so I think about snow and cold all the time. So here are the temperatures in Montreal over the course of a year. And what you see, of course, is that when it's winter, it's cold. When it's summer, it's warm. When it's winter, it's cold. But you cannot force a linear association between date and temperature, right? So this would violate the assumption made by most forms of regression analysis. So what a restrictive cubic spline does is very simple. It relaxes the linearity assumption made in most conventional multivariable regression analysis. So I'll show you how we apply this. So the first thing we did was we simply looked at risk of death. So please note this is death, not survival, plotted against time, and we compared patients who had lymph node metastases and who were under 45 and who did not have lymph node metastases. And what you see is that lymph node metastases indeed are significantly associated with survival in the National Cancer Database. And then we move to SEER, and exactly the same observation is made. That is, when you're young and you have lymph node metastases, you are more likely to die as compared to similar patients who do not have lymph node metastases. We then took these findings and used restrictive cubic splines to ask the question, does it matter how many lymph nodes have metastatic deposits in them? And it does. And what we found is that each incremental metastatic lymph node, up to a total of 6 lymph nodes, appears to be associated with decrements in survival. But after 6 lymph nodes, the burden of disease does not appear to be associated with survival, and the association is muted. Here are the actual data, and you see less than 6 lymph nodes, you have a significant finding, but over 6 lymph nodes, so this threshold of 6, you do not. So what did we conclude? So we concluded something very different than the AJCC-UICC staging system, and that is cervical lymph node metastases indeed appear to be associated with compromised survival in young patients. In the current AJCC staging system, including the 8th edition, which uses 55 instead of 45, young patients with nodal metastases almost certainly are being understaged. Why does that matter? Almost certainly if you are understaged, there is a greater chance you will also be undertreated. I'm not powerful, I'm not super smart like the AJCC, so I can't control the staging system, but I can control what I do as a provider in my clinic. And the way I've interpreted these findings is that we must do more rigorous preoperative screening for lymph node metastases in old and young patients, such that if simultaneous lymphadenectomy is needed with total or total thyroidectomy, it indeed should be performed. And so many feel that I'm coming for the AJCC. So that's a case of more is more. So you've seen 2 cases of less is more and 1 case of more is more, and I'm balanced, if anything, in life, and we'll finish with 1 more example in thyroidology and thyroid cancer where I think more is most definitely more, and that is the age-old question of surgeon experience and patient outcomes. So I'm sure many in this room actually not only know these data, but have helped to generate data showing a surgeon volume patient outcome association for different disease diagnoses and for different procedures. And I would say for thyroid surgery that is certainly not different. Many authors have looked at this question over the years. But something really weird you'll find in the literature when you do a literature review, and that is for some weird reason, when people have looked in thyroid surgery at the surgeon volume patient outcome association, they have always treated surgeon volume as a categorical variable. I have no idea why. Some authors have used these breaks, 1 to 9, 10 to 99, more than 100. Other authors have used more granular breaks, but always a categorical variable. And it strikes me, is case volume a categorical variable? I don't think so. It's a continuous variable, right? Like I do 3 cases, you do 7 cases, she does 9 cases. But for some reason, no one's really thought about it in that way. And the reason that's kind of strange, right, is that while categorical variables can be very helpful for this purpose at looking at low and high volume outliers, it does leave a gap in the middle. And understanding sometimes what's going on in the middle is most important. So a lot of people say, well, does it really matter in the end? I get it, more is better. Why do we need to know how many more? I mean, is it really important that there be a magical number, a minimum volume threshold? And for those of you who are faculty in the audience, you will know that understanding this concept of minimum volume threshold is actually critically important. Many of us, like we remember Pearl Harbor Day, we remember May 18th, 2015. On this day, leaders at 3 academic medical centers in the United States, Dartmouth-Hitchcock, Johns Hopkins, and the University of Michigan, publicly announced to their faculty a Take the Volume pledge. And what this was they asked their faculty to say if they were not doing a minimum volume of certain procedures for which there was some evidence where volume outcome associations had been demonstrated, they had to stop doing those operations. So if you didn't do enough, you had to stop doing them. And you may have trained all of your life to do some of these procedures, but based on the Take the Volume pledge, you'd have to then terminate that portion of your practice. So you can only imagine how contentious this was and how important this principle of minimum volume is. So I thought that was pretty interesting. So we started by looking in the United States, so these are national data, at annual surgeon volume. Now these are total thyroidectomies. This is not lobectomy, this is only total thyroidectomy. And what you see in the United States is that the range is from 1 to 157. And I'll tell you, thyroidectomy is one of the 10 most commonly performed operations in the United States. But if you look at the curve, this is not normative, it's not bell-shaped, there's a huge right-sided tail with the overwhelming number of surgeons who do total thyroidectomy appearing to do just 1 per year. So you remember the restrictive cubic splines. So we took the restrictive cubic splines and looked to see if we could find a inflection point, meaning a minimum volume threshold. And what we found is that indeed for total thyroidectomy in the United States, there appears to be a magical number of 25, such that each incremental total thyroidectomy done in a year up to the number 25 on average appears to be associated with a reduction in the risk of a patient having a complication. After 25, that association becomes muted or in fact disappears. So for the first time, we have a definition for a low and a high volume thyroid surgeon, and the number is 25. We then took national data, used that definition, and divided surgeons and their patients into low and high volume. And here is what we found for the first time, and that is, on average, patients who undergo total thyroidectomy by low volume surgeons have a 55% increased risk of sustaining a complication from their surgery, and almost certainly as a result of that, their length of stay goes up by nearly a quarter, and their inflation-adjusted costs go up by 7%. And here are the data that show perhaps the most concerning result from this study, and that is, in the United States, more than half of surgeons doing total thyroidectomy do just one per year, and the patients who have their surgeries done by those very low volume surgeons are at a 68% increased risk of sustaining a complication. And then you see, as case volume goes up on a per annum basis, up to 25, there is a very nice dose-response effect. Obviously, this is an association and not causation, but a very compelling dose-response effect. So what did we conclude? Surgeon volume, we've known, is associated with improved outcomes, but I think for the first time, we understand there may be a threshold number, and sadly, in the United States in 2018, the overwhelming majority of patients do not undergo surgery by high-volume surgeons like those at Stanford and UCSF, but rather by low-volume surgeons, and as a result, almost certainly are being exposed to increased risk. Well, you can only imagine how this was interpreted by payers and policymakers, and please learn from my mistake. I think in much of my life, I've focused as a surgeon scientist to trying to generate the best evidence that will impact the way we practice care, but no one ever told me that I need to focus more on how my results are presented and how results can be misinterpreted if you as a scientist do not control the message. And when our paper was published, probably within 48 hours, the New York Times, and then 72 hours, the Washington Post called us to do a story about this surgeon volume patient outcome threshold, and probably less than a day after these articles were published, Blue Cross and Blue Shield called me and said, wow, this is terrific. We are going to use 25 for all of our reimbursement and referral schema. And I will say that in this room, all of us not only must generate data, control messaging, but also participate in the conversations that are being had that ultimately determine how these results translate into day-to-day practice. And certainly for me, this was a learning experience. Obviously, there are incredible implications for data and similar data in an era of value-based care. They control how we refer patients and how we are reimbursed, and ultimately at places like Stanford and UCSF, they influence how we educate future surgeons. I guess I would finish by just saying to everyone, I think that the field of thyroidology and the field of thyroid cancer in particular is an incredibly exciting one. It is kinetic. It is, requires you to be agile, not only in innovation and discovery, but also it is important for us to accept that as data emerge, we must change how we practice surgery, how we practice medicine, keeping an open mind and understanding that change almost certainly will continue to come. Thanks so much for your time.